Cancer is a word that immediately changes conversations. It brings fear, urgency, and often confusion, not just for patients, but for families, caregivers, and even decision makers in healthcare. Yet, behind every diagnosis is a much larger story of early detection, informed choices, responsible innovations, and trust between medicine and society. Welcome to the MedTech Dialogue, where we go beyond technology headlines to explore how science, system, and human judgment come together in real clinical care. Today's conversation is especially meaningful. I am joined by Dr. Gurdeep S. Sethi, President of Millennium Cancer Center, a globally respected leader in precision and immuno-oncology and a triple board certified oncologist and hematologist from United States. With over 3 decades in cancer care, Dr. Sethi has treated thousands of patients across complex stages of disease while also shaping how advanced diagnostics, early detection technologies, and personalized therapies are responsibly brought into clinical practice. What makes his perspective unique is that he stands at the intersection of deep clinical experience and future ready medicines, where innovations must always serve patients, not overwhelm them. In today's dialogue, we will explore not just where cancer care is headed, but what every family should understand about preventions, early signs, treatment decisions, and life beyond therapy. Welcome to the MedTech Dialogue, Dr. Sethi. It is my privilege to have you on this podcast channel.
Thank you, Ashwini, for inviting me to this talk.
So, Dr. Sethi, you have a fabulous career for last 3 decades. During your graduation or MBBS graduation, when did you realize that oncology or hematology is something where you want to pursue your career?
It's a long story. I got to med school in Ludhiana and did my MBBS from there. And I always wanted to be a surgeon, so I pursued surgery in my house job and postgrad initially. And I loved orthopedics and surgery. Then I was given a chance to go to the US and I wrote all the examinations that were required out there and wanted to join orthopedics.
Okay.
At that time in 1990, the hottest residency for an American grad was orthopedics. So in spite of my experience of surgery and orthopedics here in India, I was put on the wait list. At that time, I was advised, why don't you join internal medicine? Since your scores are good, they'll take you in internal medicine. Next year you can change. So I joined internal medicine at Grant Hospital, Chicago, for internal medicine residency. And after 1 year, after doing an internship and residency started, I was called to join orthopedics. But then I declined. I says, I was married, I just had a child, and I decided to move on. The position, a fellowship position at Rush Presbyterian, Chicago. I interviewed and I got in the first chance itself. One interview, within a week I was accepted and life changed after that.
So, this was in which year?
This was in 1993 when I applied for the oncology residency, oncology fellowship. And then 94, I finished my residency. 94, July, I started my fellowship in hematology oncology.
So, tell me during that time when you started your oncology, that time, what was the treatment modality and now how the treatment modality has changed over a course of time? We have heard of precision oncology. So, if you could enlighten us.
So at that time, we saw very different things. Most of our chemotherapy that we had was the main modality of treatment. And the chemotherapy drugs were 30, 40 years old. Okay. There was a lot of morbidity with the treatment. People got really sick with the chemo. And post-chemo, 50% died from infection.
Yeah, because of side issues.
Because chemo knocks out all rapidly dividing cells. which includes your cancer cells and your blood cells, your white blood cells, your red cells, and everything. And people became neutropenic and had secondary infection and septic and died. In 1994, filgrastim was made available. This is a granulocyte colony stimulating factor,
GMC.
which post-chemo, if we gave it, kept your white cells up and allowed the person to have good immunity to fight infection. So then we got more aggressive in fighting cancer. And most of the treatment which happened in the hospital started moving outside the hospital because people didn't get sick. So by 97, 98, 90% of the treatment was outpatient in the US. Today, 95% is outpatient. Okay. So nobody goes to hospitals, everybody's in daycare centers. In hospitals also they have daycare centers. You go to a separate center, you don't have to be admitted. Treatment's done there, you go home.
That's great. So, enlighten us more about precision oncology.
Over time, things change. The first human genome break happened in 2003. That's when we were able to crack the human genome. Prior to that, we started seeing that if we targeted, we knew cancer happened because of a gene mutation. And these gene mutations created new products, new proteins, and those proteins drove the cancer. So our first breakthrough really came in with chronic myeloid leukemia. Imatinib was discovered at that time.
Yes.
Imatinib. So this was at MD Anderson in 2000, where chronic myeloid leukemias, patients, they had an average survival of 3 years. And most of them died from the disease. With treatment, they went, at that time with the modification, we had went 3 to 5 years. And bone marrow transplant was the only chance for cure, with 50% morbidity at that time. When tyrosine kinase inhibitors, imatinib, became available, it changed the whole profile. So the mutation would happen, a new protein would be created, the tyrosine kinase protein which drove the cancer, we had drugs that could block that. So with the precision TKI, the tyrosine kinase inhibitor coming along, the patient's leukemia was controlled. And they didn't need transplants, they didn't need chemo, they didn't need anything else. So they did better, and everybody went on. Anybody who was diagnosed with chronic went on this protocol at a study, and 10 years later they were all alive. So that kind of changed things.
Yeah.
Then they started looking at targeting specific protein mutations. When the gene sequencing became available, when insurance started covering next generation sequencing to look at gene mutations, in 2007, that's when the break started. And that's when we started discovering more.
Okay. So, you have lived in the US and now you are in India. So, you have seen US population also and how US clinician or oncologist in US or the awareness among the patient, cancer patient, in terms of screening, which country is more proactive?
If you look at it, in the US, most people are covered with insurance. Some have some insurance plan or the other. With the insurance that you have, you are driven to follow up with your primary care doctor once a year. And the primary care doctor is incentivized to do your screening. So there's 6 cancers for which we have screening available. So for colon, you have colonoscopy and stool for occult blood. For breast, you have mammograms. For cervical, you have HPV and pap smears. And if examination for skin cancers. Head and neck, you can do an oral exam. Everybody sees a dentist twice in a year. And so, and lung, people who are smokers, insurance and MedLife studies had shown that 30 years smoking, you do a low-dose CT scan of the lung. Okay. So these 6-7 cancers had screening processes.
Yeah.
PSA for prostate. And the doctor, the primary care, was incentivized to ask these questions, and they were paid $5 more per question in their billing and collected that.
Okay.
So with that being a routine, questions were asked, and if the patient says, no, I don't want a colonoscopy, The primary care would just document that, and when the results, when the EMR went to your insurance people, they would look at it and says, oh, you refuse a colonoscopy. You will get a call from your insurance man. And they says, if you have colon cancer, we won't cover. So people were incentivized to go for the colonoscopy. Survival out there, if you look at cancer patients, survival is around 80%. 20% succumb to cancer. In India, there's no concept of screening.
Yeah.
We don't even go to a doctor for anything until we are sick. We don't even check a blood pressure. We don't even check a blood sugar. An old man will go to the doctor for the first time, 80 years old. He'll say, Doctor Saab, I went to this doctor first time in my life. I've been healthy, and he's got out 10 problems I have. He's made me a hypertension patient. He's made me a diabetic patient. He's made me this. He says, I have anemia, I have this. I've been fine all my life. I says, well, the problem is you've never got checked. You've never got checked. It just pops. Okay. So that is a big difference. One, insurance drives it out there, and there's awareness.
Yes.
Here, everybody presents when you have symptoms, and symptoms comes in stage 3, 4. By the time you present, it's late stage. Cancer is everywhere.
Yeah, so I was going through ICMR stats, and so in India we have 1500 cases every day of cancer which are getting diagnosed, and unfortunately most of them are diagnosed at a later stage. If the patient is coming in stage 2, 3 or 4 of cancer, they have already to a stage where the survival rate is very low for those patients. Yeah.
The current population of India is 1.4 billion. WHO says 1 in 10 Indians will develop cancer in their lifetime. That makes it 140 million will develop cancer. Today, we're seeing 1.4 million new cases per year.
Yes.
We're seeing 1% of the real problem that can happen. This is what is being registered in our books in tier 1 cities and in our registries. In the villages, in tier 2 cities, tier 3 cities where people are dying from cancers, nothing is being registered, so we don't even capture that number. The ICMR says WHO is wrong. It is 1 in 9 that will develop cancer in their lifetime.
Yeah.
So that goes to 180 plus million, right?
Yeah, currently there are 2.5 million population who has cancer. Prevalence is 2.5 million in India, so it's very high.
Which is still not the correct number.
Yeah, it's the third largest among the
I'm
world.
just saying, we are not seeing the real picture.
Oh, maybe we are not diagnosing
That is right. If you were expecting a lifetime risk of 140 million and you're catching only 1.4 million, right? Something's missing. So we anticipate 10 times more. Even if you talk about 14 million, we don't have the care and capacity to take care of things. Our hospitals are already overburdened. Our government hospitals are overflowing. People are waiting for two months to get treatment. Our private hospitals are packed. Yeah. So we don't have the capacity to deliver the care. That is because everybody's coming in late stage, stage 3, 4. That's when they have symptoms. And when they hear the word cancer means, oh, death sentence. Not true. If I catch them early, stage 1, 90 to 95% cured. Stage 4, 15%. Okay. Stage 1 expenditure total from diagnosis to treatment and everything, average 200,000 rupees. Maximum 500,000 rupees, 1 lakh. Stage 4, your treatment goes on complicated over your time that you are alive, 6 months to 2 years. Your expenditure comes to average 50 lakhs. So, there's a loss of life, there's a loss of livelihood. So earning potential goes, income goes. Families who are just above poverty line go straight into poverty. So the whole family gets destroyed when one person in the family gets cancer. It's not a one-man problem in India. In the US, everybody's living by themselves. There's nuclear family, 1 or 2 members. The children, by the time they're 18, they're out of the house. So everybody's taking care of themselves. But insurance covers them no matter where they're working and all that stuff. And they have a social service system. If you don't have insurance, you have a social security number, there's Medicaid, there's help from the government. Our government here has the PMJ scheme now, giving a 5 lakh per family coverage. But the waiting in the government hospitals or hospitals that take the PMJ scheme is so long and so delayed that the patients really don't get the care they need.
In terms of screening, I know that you have started another venture in India called MedTech. Tell us more about that.
So, in my first few years, all I saw were patients who were not only stage 4, end stage stage 4. These were patients who had been to big institutes, AIMS and Rajiv Gandhi and Tata, and private hospitals, and then Ramdev and Tibetan medicine. Then they come to me, which really there's nothing much left to do. In spite of that, I do make some adjustments, give them some supportive care, some pain relief, some immunotherapies to just really do proper palliative care. And I says, why don't you come in the early stage? We'll cure you. So it was a struggle for me seeing these patients, and many times I feel they were mistreated or poorly guided because there's fear, and whatever the first doctor says, they run through.
In terms of technology of this product, if you could elaborate more and also tell us what are the sensitivity and specificity of this product.
So this is pan-tumor detect, pan-tum detect. It's a simple blood test that can detect a tumor in your body before you become symptomatic. The idea is to catch you at stage 0, stage 1, stage 2. Even 3, 4 also will show up. The patented technology is EDIM technology, which is epitopes detected in macrophages. So in your blood you have macrophages. Macrophages are natural white cells which act as antigen-presenting cells. They're scavenger cells.
Scavengers.
And their job is to pick up any abnormal protein anywhere in the body.
Yeah.
Okay. So if you have a virus or bacterial infection, these macrophages picked up that bacteria and presents it to your T cells so your immunity can fight them. When I give you a COVID vaccine, it's a dead COVID virus. These APCs or macrophages pick them up. Their job is also all the time looking around for any cancer that's developing because it's abnormal protein.
Yeah.
So they engulf the outskirts of the cancer cells, pick up fragments, and they come back in the blood. When we take your blood, we look at a very small population of macrophages. And your two proteins, APO10 and TKTL1, are present in all tumors. Your macrophage picks them up, and when we take your blood, we separate the macrophage, stain those proteins in the macrophage, and run them through a flow cytometry machine to catch. And then there's a score that's given.
So if I have to undergo through Phantom Detect test and I want to know what is my status in terms of screening, what is the procedure? How much time it takes for the results to come, and what I need to do?
So, well, you need to call us. Let us know you want the test. And so what we do is we get a blood sample. It's a simple blood draw.
Mm-hmm.
Half an hour to an hour after meals or any time before meals, right? So we need to have just 1 hour post meal. Technically, that's what it is. That's the sample we want. It's a simple blood draw in an EDTA tube, which is your CBC tube, purple top.
Mm-hmm.
Just that's all we need, 2 ml. And before you get the test, we ask you to call us. There's a questionnaire that you need to fill. So we fill out the form. There are some exclusion criteria for that. Your immune system has to be intact. We need enough macrophages in your body to be able to do the test.
So do you do the CBC count before?
No.
No.
So we go through the questionnaire.
Okay.
And technically, if you have cancer or you're on active treatment, then you don't qualify.
Okay.
And if you have any autoimmune disease on any immunosuppressants, then you don't qualify.
You don't qualify.
Or if you've had a recent scan or had fever or surgery, we tell you to wait for 6 to 8 weeks so your body recovers, then we can do a test then.
Okay.
These are screening criteria. And then we have you sign a consent saying that you agree to this test. This test has a sensitivity of 97%, which was the initial results, when we saw screening of healthy and sick patients. Those were the data that was submitted for IVDR, IVDR permission and your Indian government permission. And that's what the results was. With a specificity
that you conduct in Rajiv Gandhi Cancer.
That is right. Where we did a study for the government of India. We did with Guru Ramdas Hospital and Max.
Okay.
And where we took 180 sick patients, newly diagnosed cancer patients before they started any treatment. So we call them sick, and we took 180 healthy people. And there our results were 179 out of 180 cancer patients has tested positive, and the healthy were all healthy. So initial results were 97%, 98% sensitivity, that means true positives, and specificity was 99%. That means out of 100 healthy people, 1% tested false positive. In the real world, in Germany, they've been running it by an insurance company sells it now, and over the past few years, they've been running around 30,000 tests per year. And the data of the first 10,000, 15,000 healthy people screening, we're not seeing that 95, 97%. In the real world, the sensitivity is 82% to 85%. When we did studies with Rajiv Gandhi post-marketing, that's what also we got. We got the same results when we did studies with CK Birla Hospital. So 82%, 85% sensitivity. So the real sensitivity is 82%. What does that mean? That means if I take 100 patients with known cancer or tumor in the body, 82% of them will test positive. I'll miss 15, 20%. All right. So that's what sensitivity is. So, and the specificity is still 99%. So that's
if somebody is positive, that means
somebody is positive means, yes, we worry. No, if a healthy person tests positive, then I'm worried that he has a tumor.
Yeah, he has a tumor. That's what it means. Out of 100 cases, 99 of them will have the tumor. That's what
specificity means true negative. Out of 100 people, 99 will be okay.
Yeah,
one will be false positive.
False positive, yes.
And sensitivity out of 100 people, it's 82% sensitive. So even if you have tumor, I'll miss 15% of that. It's better than any screening test that we have in the market. The routine screening, we just do have a PSA. All right, a PSA is around 70% sensitive. The other markers that we do, the tumor markers that we do for CA 19-9, which are tumor markers, is technically for surveillance. They're 50 to 60% sensitive, but their specificity is very low. Your CA 125, which is specific for weight, can also go up if you have surgery, can also go up if you have abdominal injury, can also go up if you're menstruating, right? So it's not cancer. And 50% of people who have stage 4 cancer, the CA 125 is normal. So it's a test that's surveillance. You have a diagnosis, you have cancer, we check that level. If it's high, then it's easy to follow.
Easy to follow.
So that's the difference compared to that.
With newer AI technology coming up, where do you see are you aware of any AI technology currently which is doing a screening? And
so this is a multi-cancer early detection test. Ours is purely screening.
Okay.
We have different companies with different technology that are there. None of them are US FDA approved. None of them are IVDR approved. We are at least IVDR approved, okay? And that's what we're working on. All these companies have a lower sensitivity and we're way more expensive. So if you look at next generation sequencing, they're all liquid biopsies. All these are liquid biopsies, taking a blood sample and doing a test. In an NGS program, companies like Grail, Exact Sciences, Guardant, Cologuard, all these were companies that have been well funded, have the monies, and have done big studies at big universities. The cost of the test is an average $1,000 per test. And the sensitivity for stage 1 disease is around 15 to 20%. Stage 4 is 80%, so the combined average is 49%. Okay. So here I'm paying $1,000 and getting a test done where 50% I have or I don't have. The beauty of the test is if you test positive, it'll tell me where the tumor is coming from because I've identified the circulating cell-free DNA in your whole blood that I take. And I've been able to do my methylation technique and PCR to find out, and then I do an NGS on that. Then I know, well, this is a pancreatic cancer. Okay. So I'm able to identify where it's coming from. So the ontology can be found. As far as what we do is we just tell you have a tumor. Phantom positive means you have a tumor. Where the tumor is, what origin it is, not defined. What stage, not defined. Even in all the other ones where they say you have a tumor, it doesn't define what stage it is. It just tells me, yes, this is the ontology, this is from the colon or this is from the pancreas or wherever. That we have that answer.
So that is something which can indicate what next diagnostic you need to do, which organ you need to target.
Right.
Yeah.
So in our case, we look at a score. We look at two proteins, apoten and TKTL1. Apoten is a protein, a biomarker protein, which is a mutation that happens in your DNase X protein. So DNase X is responsible for is responsible for cutting your chromosomes when the cell gets old and cause apoptosis.
Apoptosis, yeah.
Right. So the apoptosis or apoptosis, P or not to P, is a question.
I call it apoptosis.
Okay. So in that setting, apoten has been shown to disrupt apoptosis because the DNase X are mutated and they cannot do their job. So the body then says, okay, the cell is ready to die. Create more. So the apoten number go. When the apoten is high, it just tells me there's a proliferative disease. It is a cell that's not dying. So the body keeps collecting and collecting and collecting and collecting more deaths, more cells that are not dying. They're not multiplying, they're not spreading, they're just not dying. So you land up with a benign tumor. The second protein is TKTL1, transketolase-like one. The TKT1 is responsible for changing the metabolism of the cancer cells. Normal cells use glucose, oxygen, Krebs cycle, produce energy. TKT causes fermentation of the glucose. The glucose is present, in spite of oxygen being there, it doesn't use that. It uses the pyruvate phosphate pathway, phosphatase pathway, where it ferments the glucose and produces lactic acid. That then causes the matrix to open and the cancer starts spreading. So TKT is the hallmark for malignant transformation. It also makes the patient, the tumor resistant to your immune cells and increases angiogenesis so that more blood flow to the tumor. So there are 5-6 ways of increasing the tumor growth very fast.
Yeah.
So we look at a combined score of apoten and TKTL1, and the score has to be above 260. If you're 260 and above, that means you're positive. If you're positive, you need a PET scan or an MRI to see where the tumor is. And then after that, you need a biopsy. And the biopsy will tell you the histopathology. And then you know have cancer.
Okay.
Now, so once you have your cancer, you've already had your PET scan, you'll know what the stage is. Then you go to your hospital or doctor for your treatment. Ideally, we hope we've caught you early. So if you're stage 1, all I have to do is cut it out. 99% you're cured, go home. And then follow up with your doctor and get your screening done again. If stage 2, 80% cured. Stage 3, you get full treatment around, you're 50% cured. Stage 4, get still before you have symptoms also. Sometimes you can at least get some treatment. And you have a better chance of having good quality of life. Idea is to catch you early.
Yeah.
So that you have best chance of survival, minimum cost of treatment, and good quality of life.
Yeah. Dr. Sethi, the cancer term is, everybody fears the cancer term. So are all cancer dangerous?
Well, the term cancer is bad. When you hear cancer, it is scary. And we have a lot of concept about what cancer is from our past families, elders, or previous experience where most people presented in very late stage and had very poor and difficult outcomes. So people think cancer is a death sentence. This is not true anymore. Okay. Our treatment modalities are so much better. The morbidity with the treatment is much lesser, and people do okay if they're caught early. So if you really define what is cancer, normal cells grow old and die naturally, and they're replaced by new cells. Because of mutation that happens in the genes, new proteins are produced, and those proteins drive the tumor cells to grow and not die. So if you look at it, there are over 200 types of cancers. Solid tumors are 92%, and blood cancers are 8% of the whole thing. So we've come up with a test, the pan-tumor detect. It is truly for the solid tumors. Studies haven't been done for the blood cancers, so we cannot claim that it covers blood cancers. That's what we have in the market today.
So, so what is the difference between cancer and tumor? Are these interchangeable word, or there is a
Tumor
difference?
is a benign layman. No, tumor is a layman's term.
Tumor is a layman term. Okay.
Tumor can be benign or malignant.
Okay.
Cancer means malignant. So a benign tumor is not really cancer. Cancerous growth means that's something that's going to grow and multiply.
So, what are the risk factors to develop cancer?
Well, there you go. This is an important question. If you look at it, there are 8-10 risk factors which we can modify, and 3-4 which we have no control over. The main cause of cancer today is, number one cause is tobacco. Tobacco, smoking, chewing, vaping, any type of tobacco use increase the risk. It's associated with 12 to 14 types of cancers in the body. The number 2 reason for cancer today is obesity. In the Western world, obesity is caught up with tobacco as main cause of cancer. 3 is your junk food. The food that we eat today is all processed food. All your processed meats, your bologna, your sausages, they're all processed foods. With the processing, there's a lot of chemicals added to it. Right? So we don't have home-cooked natural food. We have everything. We have Ziggy, Zomato, everything is coming. Number 4 risk factor is inactivity. Sitting, I feel, is the new smoking. Okay, our physical activity has gone down to minimum in big cities where we are working. We drive to work, takes an hour. We're working all day at a desk, and then we drive back. And then we're in front of the TV. So, no exercise, no gymming, no outdoors, no sunshine. So our lifestyle is important. On top of that, if you have certain infections, HPV infection, HIV, hepatitis, these increase risks for cancer.
Yeah.
Okay, we're known associated. The above 3-4 factors we talked about, obesity and junk food and inactivity, increases your risk for chronic diseases and metabolic syndromes, includes diabetes. People who have metabolic syndromes have a higher risk of cancer. There's inflammation in the body. And then, depending on the type of work you do, if you're working in an industry where you're exposed to chemicals, toxins, pesticides, working in tire factories, petroleum refineries, your risk of cancer goes up very high. So these are what I feel are controllable factors. If you change your lifestyle, avoid all this stuff, we can. Alcohol, 7 different cancers. Okay. And alcohol, now we're seeing much more problems coming in, but is a socially accepted. The ones which we can't do anything about are genetic mutation. If I'm born with a mutated gene, inherited mutated gene, then my risk of cancer is already up. There's nothing I can do about it other than getting checked. If I have a strong family history, 4 or 5 members, my risk is higher. Now, if I I'm living in a city where the pollution is very high. I'm living in Delhi. I can't move to Switzerland. So I can't control the environment. These are few factors I cannot control.
Do you think the incidences of lung carcinoma in Delhi, particular Delhi and NCR region, pollution could be one of the big factors for that?
It is not, I think, it's a known fact, it's proven.
It's proven, okay.
Smoking used to cause cancer. Lung cancer used to be in the Marlboro men, right? And it happened at the age of 60, 70. You have to have 30 to 40 pack years of smoking. 1 cigarette per day, 1 pack per day. For 1 year, 1 pack year. So 30, 40 pack years before you develop lung cancer. It was predominantly in male, now females are catching up.
Yeah.
In Delhi NCR, studies have been done at Gangaram and other hospitals where we are seeing now lung cancers in 30, 40 years old. And the incidence of cancer is equal men and women.
And they don't have a smoking history as well.
And
Some of them.
50% don't have any history of smoking at all.
Yeah, then that proves clearly that pollution.
You're born smoking, right? Because you're breathing the air. And by the time you're 30, you already have all the exposure. And that's when you develop lung cancer. Never heard of, never seen before.
Dr. Sethi, what is this Phantom test?
Well, Phantom test is a test that we have for a detection of any tumor in the body in a healthy person. This test is for you and me. No history of cancer. A regular person. It's a screening test. Today, we do have, based on the risk factors we discussed of all that we have a questionnaire which can address all these questions. And if you have 4 or 5 risk factors already, then the risk of cancer is high, developing cancer is high. If you're at a higher risk, we do recommend a screening test, a multi-cancer early detection test. And Phantom Detect is the test that we have available for the public. Pan-tumor detect. It's a simple blood test that can detect a tumor in the body at any stage, at any time, before any symptoms come in. Right? It's a blood test that's taken in an EDTA tube. And in this, we look at 2 proteins, APO10 and TKTL1. APO10 is the hallmark for benign tumor because it's cells that are not dying and just collecting. And TKT is responsible for malignant transformation. It changes the metabolism of the cancer cells with the Warburg effect, where you ferment your glucose in spite of oxygen being available. So, should you test positive, we look at how do we categorize your tests with the APO10 and TKTL1. We give you a score after we do the test. And if your score is above 260, it means you have a tumor. At that setting, we then tell you that you're positive, you need to see your physician, who will guide you through a bunch of blood tests and a PET scan. And based on the scan, where the tumor is, we do a biopsy. And then we get a tissue diagnosis and you have a diagnosis of cancer. If your score is less than 245, then you're normal. That means whatever you're doing okay. Continue and come back after 1 year. Between 250 and 260, your risk is already high, but you don't have a tumor. What we tell you to do is change your lifestyle.
Change your lifestyle,
Yeah, this is the wellness column. All right, stop smoking, stop alcohol, get active, lose some weight, and get retested in 3 to 6 months. If your score drops, then we know that it is all from inflammation. The 2 proteins we look at is TKTL1 and APO10. APO10 is not influenced by inflammation. TKTL1 can go up if you have inflammation. If you're obese, if you have chronic inflammation in the body, if you have metabolic syndrome, your number can be higher. And that's where we see most of the people in NCR are sitting at 257, 258, and they're worried whether they have cancer or not. 260 is the cutoff. So we repeat them in 3 to 6 months with a lifestyle and wellness change.
Are there any role of diets also and dietary supplements also? Have you seen the score coming down if...
So if a person comes in today and his BMI is 35, he's obese, overweight, and he likes to drink alcohol and he smokes, and he hardly works out, right? His score may be 259 or 258. First thing I tell him is, all right, you need to stop smoking. Number two, you need to change your diet. Your Ziggy Zomato diet has to change. Number three, you got to lose weight. So I try to motivate them to get into an exercise program and lose weight, lose some weight. All right, I need your BMI at least between 25 to 30. You have to be not obese. You can be overweight. And ideally 26, 27 is okay. Less than 25 is normal. Right. So that's number one. When you're motivated to do that, then automatically your diet changes. I have nutritionists and dietitians who will help you modify your diet. Home cooked food, regular food intervals, no junk food in between, okay? And certain foods are very important for your body. That is a whole nutritional plan that can be always discussed when a patient does come in or somebody does come in for that. Supplements. Certain supplements are very good. Probiotics are very good. You have different probiotics that come along. Your very good anti-inflammatory, which happens naturally, is your turmeric, which has a lot of curcumin. We know it's a nice anti-inflammatory, natural food. And helps in as a very strong antioxidant. All your antioxidants, your vitamins, your multivitamins, your vitamin D has to be normal.
Yeah.
Vitamin D is very good for your immune boosting and helps all your other vitamins which you require in your body anyways has to be appropriate. Because if I start breaking down every vitamin, we have different deficiencies and different problems.
Different problems.
But when a person comes to me, I make sure I check the whole setup, and whatever has to be corrected, we correct, and then motivate them to do the right things. Coming in the long term right now are the new GLP-1 and GP drugs.
Mounjaro
and retatrutide and tirzepatide. They are going to be, because they are ideal drugs for metabolic syndrome.
Yeah.
Right? It'll take the inflammation down. I see it coming as a treatment in cancers too. Okay, it takes the inflammation down. That's something that hasn't come yet, but studies are going on.
Okay.
Where we're seeing good results.
So what are the costs associated with the Phantom test if somebody wants to get screened?
So today, the current MRP market price for the test is 12,000 rupees. The test is recommended once a year. Okay. The cost being high is because the antibodies that we use to stain your proteins are being imported from Germany. Ideally, I'd like the cost to be less than 5,000. I've talked to the German partners about producing the antibodies here in India. So we've been promised where once we reach a certain volume, they'll bring the production of the antibodies to India. Where can we produce it here? And in India, they'll make sure that this hub will be the production of antibodies for all of Asia and Africa instead of producing it in Germany. With that saying, our cost of the test goes down tremendously. We can hit that less than 5,000 rupees test, and it should be available to all, not only the rich or wealthy. Goal is to be able to get a general population, the maximum number of people at higher risk, especially 40 and above, to get them tested once a day.
That's great. Because if the costing is less, then it can reach to masses as well.
That is correct. We want to do mass screenings. We're working with governments, we're working with insurance programs, we're working with corporates, we're working with CSRs to help the underprivileged to get tested.
Does it make sense for, at least for the population who has a known associated risk factor? Suppose someone is having family history of, let's say, breast cancer or oral cancer or lung cancer. I think those populations are at higher risk of developing cancers, who are family related population I'm talking about. So do you think that makes sense for at least for these population to get screened?
So today, this test is available in the market. I run an oncology setup and I see patients, I do practice. And most of my patients that come in, they come in with the family. So there'll be 4 or 5 members of the family. I focus on the patient, and once they're more stable and all that, then the family member who's sick, the patient who's sick will ask, okay, I'm okay. What about my son or what about my wife? So the whole family then get tested. Okay, so that's recommended if you have family history to do that. We also have a multi-cancer risk assessment questionnaire, which addresses all those risk factors we talked about. And if you fill the questionnaire, you'll know whether you have a higher risk or not. This test is recommended for everybody 25 and above to do once a year. Now, if you're negative 2-3 years in a row, the risk of developing cancer goes down, because for cancer to develop, you have to have mutations, and it takes 4 to 5 years before something shows up. All right. Now, people who live in NCR and places where there's high pollution, technically you're smoking a pack a day already. And if you've been here more than 10 years, you're already at a risk factor. If you're 40 and above, you need to be tested. Okay, it's for those people who are older. And family history being there, different drug and alcohol and tobacco exposure and risk factors we talk. This test is recommended for all those people.
So, how successful has been Meditech India and the Phantom test till now? And what are your future vision for that?
So, we got the approvals in early 2023. And it took us almost a year to really get into the level of defined expertise where our test was less than 1% rejection compared to the Germans, because they had an automated process and then the regular screening that we did with the BD machines and flow cytometry. So once the German says, okay, Dr. Sethi, you're ready to go to the market and reaching the masses and start screening, we approached hospitals and did studies with them and talked to them about screening, thinking that the doctors and hospitals would adopt them earlier. But there has been a lot of resistance or poor uptake because of lack of awareness.
Okay.
First question everybody asks, is this FDA approved? It hasn't gone to the US yet. It's available in Europe and 35 other countries. Okay.
But it's a CDSU and ICMR approved.
Yes,
so
it is IVDR approved and IVDC approved.
And then as a regulator, I can watch that getting approval from European authority is difficult compared to US FDA. So that's one big statement I would like to reiterate here.
So we are now talking to corporates, we're talking to insurances, and we're talking to governments with CSR programs to get it to the masses. We catch the disease early, we cure the patients, and our cancer burden will go down.
Thank you, Dr. Sethi, for your wonderful insight, and it was a privilege to host you here. We had a lot of good insights on cancer. We also learned what are the risk factors for cancer. We could also see that screening is one of the greatest tool for cancer prevention. So that is something we all should be doing. Maybe once in a year, getting screening is done is very beneficial compared to if you are getting cancer later on. So thank you, Dr. Sethi, for a wonderful insight and coming to the MedTech Dialogue.
Thank you, Ashwini. Thank you so much.